Hello, it's wonderful to be here with you all today. My name is Roshni Koli. I am a child and adolescent psychiatrist, and I'm the Chief Medical Officer for the Meadows Institute. I am grateful and honored to be joined with two wonderful colleagues today to talk about innovative policy solutions to bolster the mental health workforce. To introduce our colleagues, Luanne Southern works at the University of Texas System as the Executive Director of the Texas Child Mental Health Care Consortium. She has extensive experience in health and human services within the government, nonprofit, philanthropic, academic, and private sectors at the national, state, and local level. Her career has been focused on increasing access to pediatric mental health care and ensuring that all children and families get the care that they need. I know her as a respected colleague, as an individual who can get people together to get things done and champion children's health. Dr. Kimberly Avila-Edwards is a general pediatrician and the Associate Chair of Advocacy for the Department of Pediatrics at Dell Medical School. She is a seasoned pediatrician with well over 2 decades of experience. She has served in state and national positions in advocacy and policy for the Texas Pediatric Society, the American Academy of Pediatrics, Texas Medical Association, and the American Medical Association. In addition to her incredible clinical work and all the individual children and families that she has helped throughout the years, she has also taught and mentored medical students, residents, and other physicians, including myself, in how to effectively bring a clinical voice to policy initiatives to impact change. Welcome to you both. To start this off, I want to set the stage of where we are within children's health. So 1 in 6 children have a mental health condition, such as ADHD, anxiety, or depression. We know that mental illness is a pediatric illness, with over 50% of all cases presenting before the age of 14 and 75% before the age of 24. And yet there is an 8 to 10 year delay from onset of symptoms until treatment is initiated. The COVID-19 pandemic has only exacerbated a growing mental health crisis for our country and our world. In fact, in October of 2021, 3 major organizations focused on children's health, American Academy of Child and Adolescent Psychiatry, American Academy of Pediatrics, and the Children's Hospital Association, came together to declare a national emergency in youth mental health. And things continue to worsen. In February, the CDC released the results of the latest Youth Risk Behavior Survey, which showed that over 40% of high school students experienced feelings of sadness or hopelessness that prevented them from engaging in regular activities for at least 2 weeks within the past year. And 57% of teen girls felt persistently sad or hopeless. About 30% of high school students seriously considered suicide. This was up 60% from the prior decade. And our workforce shortage really impacts our ability to effectively deliver mental health care for the children who need it. In Texas, there are approximately 10 child and adolescent psychiatrists per 100,000 children. ACAP, our American Academy of Child and Adolescent Psychiatry, estimates that the need is nearly 5 times that amount. So we have workforce challenges, we have a growing and present mental health crisis. What we'd like to share with you today is what we as a state have looked at in terms of innovatively addressing policy. Luanne, I'm going to start with you. Texas has invested a historic amount of funding in improving access to youth mental health over the past 3 legislative sessions. Can you walk us through the initial vision for that funding?
Sure. First off, thank you so much for inviting me to participate and talk about what's happening in Texas. We have a lot of exciting things going on here. In the 2019 legislative session, Senate Bill 11, was passed in Texas. And what that bill did was to create something called the Texas Child Mental Health Care Consortium. Our consortium was created to improve access to services for children with mental health needs and their families across the entire state of Texas. The thought being that regardless of whether you live in a very rural area of the state or a huge urban area like Houston, children should have access to care, and that access should happen as early as possible. One of the ways that we know that we can improve access to care is through several means. One of those is the early identification of issues. Roshni, Dr. Koli spoke earlier about the importance of early identification, because we know that if we can identify situations and issues early enough, hopefully we'll be able to address them and treat them to prevent those needs from getting more and more severe and more significant. So part of the goal is to provide early identification that improves access to early identification. Then the other one is telehealth. We know that in order to improve access, regardless if you are living in a rural versus urban area, we want to be able to provide access to mental health services by using telehealth, by using technology. Another issue that I believe the bill does is to recognize the importance of primary and mental health service integration. And that's why I'm so glad my colleague, Dr. Edwards, is here representing the pediatric primary care field of practice, because we cannot do our work for children's mental health alone. We have to do it together. And so I think the legislature recognized that programs need to be set up to really address the integration of primary health and behavioral health. And part of that, as Roshni alluded to earlier, had to do with workforce shortages. We know that more children access behavioral health services through their pediatric primary care provider than they do through their behavioral health provider, because we have a shortage of behavioral health providers. And so the services that were set up through that consortium include school-based telehealth, include the integration of pediatric primary care through consultations with children's mental health specialists. We have also several workforce initiatives that we're very excited about to expand the number of child and adolescent psychiatry fellowship slots that are available in medical schools across the state of Texas, and also to provide child and adolescent psychiatric residents with opportunities to do community psychiatry within provider organizations across the state. So that's a nutshell. We also have a couple of research initiatives going on, because there's a recognition that we need to start thinking about, again, those evidence-based practices. What works? How can we get more of what works in the state of Texas? So we have one that's focused on trauma and the impact of trauma on children's mental health, and another research network that's focused on suicide prevention and depression.
Wonderful. Thank you so much for that overview, Luanne. It is certainly an impressive number of programs that have all been launched within just the last several years. I'd like to spend a little bit of time talking about CPAN. You know, we talked about the importance of integrating mental health care into primary care, knowing that really primary care pediatricians are oftentimes the first line for any health concern for children and their families. Dr. Avila-Edwards, could you speak a little bit about what it has been like as a pediatrician to access the child psychiatry access line?
I would be happy to, and thank you again for you, Dr. Koli, to invite us to be part of this just an important conversation. And thank you, Luanne, for everything that you've done to support pediatricians like me in our state. So what I would say is that the Child Psychiatric Access Network has been invaluable. As a primary care pediatrician, I can tell you that over the course of my 20-year career, there has absolutely been a significant increase in children coming to me with their primary complaint being a mental health complaint. And I have seen it over the course of my 20 years, definitely with a rise with the pandemic, but it started much before. I think it's allowed me to build in that ability to treat and manage and identify the needs of the child and the mental health diagnoses right then and there without the delay of needing to refer them elsewhere. And especially it has been critical in a busy clinic practice. I think the collegiality, the collaboration and partnership with our regional CPAN team has been outstanding, from answering my questions or confirming my treatment plan to helping me manage more acute needs and help with community resources. I have been so appreciative and indebted, and my patients have received the care they have needed and deserved in real time, which is what is critical. And I think over the course of my career, I've practiced in a few different clinical environments, both within a multi-specialty group practice where we did see privately and publicly insured children, and I practice on a mobile clinic that treated 100% uninsured children. And what I will tell you is in both clinics, the gaps in mental health services was absolutely appreciated, but there are disparities for children who are under or uninsured. And that environment really made me take that responsibility of treating my patients in real time. And I was able to do it with the support of the CPAN staff. And I really cannot thank you enough for that.
It's wonderful. Thank you so much for sharing your experience about what it's like to have CPAN as a pediatrician. On the child psychiatry side, I still continue to take CPAN shifts and serve as a child psychiatry consultant. And it is one of my favorite roles, one of my favorite things that I've ever done in my clinical career. And I think a big reason is that it really offers what you described, that collegiality, that opportunity to build and strengthen relationships, that opportunity to get to know my pediatric colleagues and to feel like we are in this together. That there's something in part of this conversation that we can provide some evidence-based recommendations. We can help to hopefully make things less intimidating, less scary, to feel that mental health care is more approachable and doable. And one of the things that I've really been impressed with is that pediatricians are already doing an incredible job managing mental health concerns within their practice. In fact, I think as we think about adult mental health and pediatric mental health, one of the things that I note from our CPAN calls is that our pediatric providers are actually doing measurement-based care. They're already screening and tracking symptoms as it relates to depression and anxiety, and then they're tracking the improvement or the lack of improvement over time. So we have this sort of perfect setup to be able to enhance the type of care a child receives. Luanne, I'll turn to you again and kind of if you could talk a little bit about the financing. We've talked about that, there's been a record investment. How do you think that the legislature has continued to reinvest and refund the Texas Mental Health Care Consortium? And how do we continue to make that case each session?
Well, that's a great question, Roshni. And one of the things that we're so proud of is the fact that our legislature did recognize children's mental health needs, and this was pre-pandemic. The consortium was created in 2019. The Texas legislature meets every 2 years, and in that initial session, when the consortium was created, our budgets in Texas are biennial budgets because the legislature meets every 2 years. That first biennial budget was $99 million of general revenue, which is a significant investment in the consortium and its work. That revenue, the way it's structured, and I always like to talk about this because it's sort of unique. The consortium itself engages the 12 academic health science centers, we call them health-related institutions in Texas, that have schools of psychiatry. So there are 12 university health-related institutions across our state that have schools of psychiatry. It's all of the University of Texas system. And then we also have University of North Texas in Fort Worth. We have the Baylor College of Medicine in Houston. We have Texas A&M, and we have Texas Tech El Paso and Texas Tech Lubbock. Those 12 institutions receive their funding through the Texas Higher Education Coordinating Board to do our work in children's mental health through those schools of psychiatry. That's a very unique structure in terms of how the revenue flows from the Texas legislature to the Texas Higher Education Coordinating Board. Most children's mental health funding comes through state health and human services organizations. Our funding comes through academia. So that makes it very unique. And it also helps us to engage academia as significant providers in the children's mental health services system in our state. Since the time we were first created in 2019, we also, in this latest legislative session, which was just this year, received an appropriation, a 2-year appropriation of $337 million. So we have significantly grown in terms of our resources and in terms of our reach since the beginning in 2019. So over the course of the last 4 years. Also in between that time, 2020 hit. The pandemic came along, and then we started seeing, as you alluded to earlier, Roshni, the significant issues that our children and adolescents across the country are faced with in terms of increased rates of suicidal ideation, of depression, of anxiety, and the significant impact that I call it trauma, grief, and loss that covered the world. Every single person in the world was impacted by the COVID-19 pandemic, and our children were no exception. And so in the infinite wisdom of that original creation of the consortium in 2019, we were ready and prepared to expand those services to address the needs of children in our state, using those academic institutions as the key hubs in 12 regions of our state to be able to do that.
And it's really been such an incredible effort to bring all of these academic institutions together and to really create sort of a standardization of process for how we implement these programs within the state. One more follow-up question with that is, how are we assessing outcomes, or what are our metrics for success?
Well, as a matter of fact, when the consortium was started, the leadership, the executive committee determined that we needed to do both an internal evaluation, so that we developed metrics to look at how each of the initiatives that we're implementing are doing. And we also have an external evaluation that gives us an idea of how we're doing in terms of addressing needs more broadly in the state of Texas. And so we have done an extensive job working with 2 entities. We have a contract with a university system to do the external evaluation. We have a contract with another university to do the internal evaluation. And then we have this entity that we call the Centralized Operations Support Hub. That is a centralized place that has our 1-888 number for the Child Psychiatry Access Network and our new perinatal psychiatry access network. And they also have a data management system, so that information from each of those 12 regional hubs that are led by our academic health related institutions, the data and information goes into that centralized database so we can track how we're doing. Now, what we track are things like, we want to make sure that with the Child Psychiatry Access Network, what's the distance between when a pediatric primary care provider makes a call to when the call is answered and the consultation occurs? Because we want to make sure that we do that in a timely way so that pediatric provider gets what they need in a timely fashion so that they can address the needs of that young person that is accessing their care. For school districts that are involved in our school-based telehealth program, we are tracking how many schools are enrolling in the initiative, how many students are referred. Out of those referrals, how many students are being seen? What's the time frame between referral and actually receiving care, so that we make sure that we can report how we're doing with specific metrics. We also are looking at parent satisfaction. Do parents feel like that student, their young person, their child is getting better or not. And we want to be able to look at that. So we're looking systemically at how we're doing in terms of rolling out our initiatives from a quality improvement perspective. We're also looking at metrics that pertain specifically to how we're doing in terms of our relationship with our customers, which are schools, pediatric primary care providers, maternal providers of services to pregnant and postpartum mothers, and also how we're doing just in terms of our own relationships that our academic institutions have within their community when we're implementing our workforce initiatives.
That's a great overview. Thanks so much, Luanne. I think those are so important to really look at what are the things that we're tracking? What are our metrics for success? And I want to highlight one thing that you mentioned, which was also supporting our moms. And I think, I don't know if we've mentioned yet about the expansion of CPAN to PeriPAN to also be able to support our mothers. And so when we think about pediatric mental health, I think it's so important for us to recognize that pediatric mental health really starts within the womb. It starts with the mom. So if we have a healthy mom, that's our best way of ensuring a healthy baby, both physically and from a mental health perspective. So I think really that expansion has felt like a very natural evolution of the network. Dr. Avila-Edwards, I'd like to turn it over to you. You know, you have such an incredible record of how you've been able to effectively utilize a clinical voice to impact policy. Can you speak a little bit about the role of advocacy as it relates to children's health and what your experience has been in that regard?
Absolutely. And thank you for your collaboration on so many efforts in that realm. I would say that the gaps in mental health care for children and adolescents are a threat to children, to their health and to their well-being. And the role of advocacy is really for us to be the voice for children about this need, to bring about that needed policy or regulatory change that is needed. And through advocacy, we raise awareness not just about the issue, but we give an on-the-ground view of what is happening in our communities, what is happening to our children and families. We're able to combine the stories of the children in our community with the lives touched as our patients, our neighbors, our classmates, alongside the statistics and data to make and help our policymakers understand what we are facing. So, you know, we are a trusted voice in the community, and both for our patients and for our policymakers, and to be able to raise awareness of gaps in education. I did not, 20 years ago, got very little mental health training in my educational residency background, and I was not an adult provider. So the ability for me to share that as much as I am dedicated to children, I need the support from the Mental Health Consortium to fill those gaps, to help me and prepare me to be able to address the mental health concerns in children, and for my moms, who we did start screening for postpartum depression a long time ago. I remember so many of my colleagues were terrified because we don't, as pediatricians, know the adult realm. So to be able to raise awareness of how, if we're treating children, if we're seeing them in our community, the importance of having that holistic approach of treating the parents and the moms, along with the importance of how funding for the Mental Health Consortium and the programs through it are of benefit to our community, is how we advocate.
Thank you for sharing that, and really being able to, that link that you described about bringing clinical stories and combining them with best practice, evidence-based, and your view as how to practice best practice medicine. If we start to think about, we've done some really wonderful work in Texas to bolster programs that are really being able to increase access to care for mental health for our children and families. What do you think are some policy changes that may still be lacking? Where do we go from here, in particular as it relates to our pediatric primary care providers?
Such a great question. And I think I'd like to start by sharing a bit about the progress, as well as my appreciation and gratitude for policy changes that have been proposed. From a federal perspective, the Biden administration just recently released some proposed rules to increase access to mental health services. And the proposed rules require insurers to, one, provide coverage for mental health and substance use disorder in parity with coverage of medical and surgical care benefits. And two, the proposed rules will ask that action be taken to address any gaps. So I express my gratitude to the American Academy of Pediatrics for submitting comments on these rules on behalf of the AAP-led Child and Adolescent Mental Health Consortium. But we do have a long way to go. If we look in our communities, a third of children their mental health conditions are being treated exclusively by primary care pediatricians. And so there are policy progress steps that are still needed. And, if I had to delineate them, one, I think we need to invest in prevention and early intervention services to work with young children. We need programs like the Community Mental Health Service Block Grant Program to be funded by Congress, because it's through these programs that prevention and early intervention services for children are going to be funded, and how we will allocating the funds through or from the SAMHSA Mental Health Block Grant will be able to give us the tools that we need to intervene as early as possible. Two, I think we need state and federal policymakers to invest in the training of existing and new providers to address that continuum of mental health care, while also prioritizing opportunities to grow a more diverse mental health workforce. And we, need to look at programs such as loan repayment investments. And there has been a tremendous amount already invested, both at a state and a federal level, but absolutely more is needed. And then finally, I would say we really need to rectify inadequate payment rates for behavioral health services, because inadequate payments currently make it difficult, and I know you know this, Dr. Koli, for child and adolescent psychiatrists and other mental health professionals to sustain a career in the field. And when we're talking about payment, we need to pay primary care pediatricians for the mental health care they're providing. What I'll do is mention that there is currently limits on same-day billing in private and public insurance, so that a patient can't be seen both for a medical and a mental health condition by separate providers on the same day, and or even the same provider on the same day. So there's bipartisan legislation in the U.S. Senate that would address this major barrier. And I think that just speaks to the fact that we really need to see mental health and physical health as one, as really child well-being, and we cannot delineate one from the other, and really understand and have our policymakers understand that investments have to be made for both.
I couldn't agree with you more, and I appreciate how clearly you delineated some of the action items that we really could take in terms of really thinking about effective policy changes that could bolster the way in which we support our primary care providers, that really integrating mental health care into that primary medical home. Well, we are, coming to a close soon. So I want to start with, I want to end with a final question. We've talked so much about many things that are going well, the creation of incredible programs within Texas that are innovative, thoughtful, and that are meaningfully impacting access to mental health care within our communities. And we've talked about just the roles of relationships of pediatricians and child psychiatrists getting to know one another better and to be able to really empower and support primary care providers. I guess where I'm left with is what's missing. What we've talked a little bit on the policy side about what we have to go, what things we need to achieve. Luanne, I'm going to start with you. Is that if you had a magic wand and you There were no obstacles, administrative, bureaucratic, workforce, all of those things. If you had a magic wand and you could do one big sweeping change, what would it be? What do you think would most greatly impact pediatric mental health?
Well, if in an ideal world, we would make sure that all children, regardless of where they live, would have access to a full array of services, all the way from early intervention when they're 0 little babies, all the way through until they graduate from high school and beyond, frankly, for our college age youth and youth transitioning from the child to the adult systems, and just had access to that full array of health and well-being services that really help them thrive in community and in school and with their families, so that there was every single type of evidence-based service that we know works was available. And the other thing, Roshni, and this panel is proof of that, because we all three of us work together, and we work together very well. We cannot do this alone, and the days of thinking in siloed terms, in terms of funding, in terms of providing services, they're just over because of the workforce issues that we all have. We have to engage peer support. We have to engage youth in our work with lived experience. We have to engage individuals with credentials and individuals who provide that community-based support to children and families. It takes all of us together to really make services work and to help children thrive. So that would be my magic wand moment.
That's a pretty incredible magic wand. We would say
well, you said no holds barred, so hey, I just went for it.
That's right. I love that. I think it's so important for us to have sort of a vision of what could be, and then to start to really think about the steps that we need to get there. Dr. Avila-Edwards, how about you? What would your magic wand solution be?
And I could not underscore enough some of the things that you said. I would say absolutely that every child, in a very equitable way, get the care they need and deserve right at the moment of need. Again, from prevention, across the continuum of care, from prevention all the way to high acuity, when we see, and I know we didn't have very much time to talk about this, but when we see our children coming into the hospital system, into the ER, that the beds that they need are available, that the community resources, like you said, the peer support, the parental support, that we would have it all at our fingertips. And if I had one more magic twist to give, it would be to have an integrated mental health provider in all of our clinics. I've seen the success, Dr. Koli, that you have had in subspecialty clinics, that I've seen in some of the primary care clinics that some of my colleagues work at. And it is amazing because we are a team, Luanne. We are one and the same. To have everything housed together is just a dream.
I think what I'm hearing from both of you is really two things. One is that we're really kind of creating a vision of integrated health, right? That there is no primary care without mental health care. There's no mental health care without primary care, that we really need to be able to think broadly, and that our solutions can't be siloed. They have to be with one another in a community. And the other that I'm really hearing is that continuum of care. We talk about that so much, but what does that really mean? And I think to expand that continuum of care from talking about pediatrics, really talking about maternal health, that we're really thinking about that continuum all the way from maternal health to pediatric mental health and well-being, and then to transition age youth. We're thinking about all of the vulnerable time periods in an individual's life. I know for me, when I had my first little one, and in that postpartum period, that's oftentimes a pretty scary time, having your first little one. And so to have that support, to be able to really think about how much I appreciated and still appreciate my child's pediatrician. And then to be able to really be able to give back within that way, to think about how do we put best practices about parenting, just like we do well child checks, and we're thinking about preventing using seatbelts And we're thinking about prevention within that. What does prevention at a mental health stream look like? So lots of good ideas and wonderful things to think about and talk about. So one final question that I thought of is really thinking about always from a pediatric standpoint. And as a child psychiatrist, I really like to think in hope and strength-based approaches. So Dr. Edwards, I'd like to ask you, what brings you hope as you start to think about where we are today and where we're going?
Great question. One, I'm hopeful because of the collaborations and the partnerships that we've built. I have gotten to know so many of my colleagues in the mental health world so much better, and that has brought so much strength for my patient care. I'm hopeful because we have really started integrating mental health into our well checks in a way that really normalizes things. To be screening for depression at our well checks has really brought a decrease in stigma for our families, to see families recognizing the symptoms in their child, to be able to ask and not feel the shame that at one point I know was part of the barriers for our children to come in early. I am so hopeful and thankful for that. And I have both of you to thank so much for that.
Thank you. Luanne, how about you? What brings you hope?
Well, I agree fully with what Dr. Edwards said in terms of stigma. One of the things that happened as a result of the pandemic is that we have heard so many more conversations about mental health. What does it take to be well, to be healthy? What does it mean when we talk about well-being? And I think, just as Dr. Edwards said, because some of the barriers around talking about mental health and seeking mental health services, they're slowly eroding away, especially when we have famous people who are not ashamed anymore. Sports figures, movie stars, musicians, individuals that young people see on social media that are talking about their mental health needs and their mental health struggles. And I think in the news, we see it on television, we read about it, it's everywhere. And I think people really want to know, what does it mean to be mentally healthy? What does it mean to access services? And it doesn't mean anything. It doesn't mean you've done anything wrong. What it means is that you are seeking health and wellness, and it's okay. And you're not alone, and that you can recover from it, and you can function and thrive. And so I feel very encouraged about that. The second thing is that I think that across the years, and I've been in this business a very long time, the way that we are incorporating individuals with lived experience into our work as partners in how we do business is essential for us to move forward. They sit at the table, they are partners, they're helping families navigate through these very complicated agencies and systems. And that is wonderful. And I'm very, very thankful for that and very excited about that.
Well, I couldn't say it any better. That is beautifully stated. And I am so grateful for you both and for what you bring to the table and for the incredible work that you are doing to bring access to pediatric mental health care for all individuals. Thank you again for being here today.
Thank you so much.
Thank you.
Luanne.